I have the honor to present Professor Ahmed Adam, who is going to present age-adapted immunosuppression in transplantation. Professor Ahmed Adam is a professor of internal medicine and nephrology and pulmonary.
Thank you very much, Mr. Chairman. It's my pleasure to be here, and primarily I would like to thank Professor Maher Fouad very much for getting me involved in this very prestigious conference. أستاذ ماهر علمني كتير وأنا لسه فخور لغاية دلوقتي كنت بكلمه بالتليفون فبيقول لي يعمل إيه في الحالات.
ربنا يخليك.
والله. The topic of today is
بس على فكرة هو بيكلمني عشان يقول لي نفس السؤال بتاعك عشان اقول له عشان يوصله لي.
طبعا جاي حضرتك
ما صدقوش.
لا انا يعني ما اقول فعلا.
دكتور ماهر استاذنا كلنا.
The title which was given to me is Age-Adapted Immunosuppression in Transplantation. And the agenda includes debatable conclusion as I used in the last couple of years, so as if I haven't answered, at least I will give you the message. And the agenda, and I couldn't fulfill it, is age pharmacokinetic of drugs, pharmacodynamic of drug, pharmacogenetic of drug, molecular biology affecting age, and immunosuppression adapted by age, which, like the example of the case yesterday presented, after 22 years you get the level down because of tolerance. Age-adapted immunosuppression, when, how, and why, and what dose. Still in the agenda, there is a difference between the nomenclature and the general principle of pediatric and drugs which avoided, and is it the age of the recipient, or maybe the donor kidney age. And we may finish by the final conclusion. Primarily, why transplant different age? Because of this graph, it is given up to date about 10 years ago. And 2005, as you see, 0 to 14, there is a big difference between transplanted and kid rather to keep him on dialysis. At the same time, if you go to the extreme, still in the aging population get benefit of transplantation, provided, of course, that no contraindication. So, debatable conclusion include pediatric is not adolescent, is not adult, and is not very old, and each has rate and time and patient confounding factor, and you must plan ahead for your immunosuppressive, but not only that, but you must adapt your predetermined plan in accordance with what really happened to this your particular patient. And our mission impossible is long-term graft survival with the least adverse effect, and not only minimization, not withdrawal. And acute rejection, acute graft function is not so far a problem. Our problem is the long-term graft survival. And the best immunosuppression has not been established yet, as tolerance is still not found. There is no single ideal immunosuppressive protocol, none for a single patient all the time, but there is an optimal protocol for a patient at a certain moment to serve a certain purpose. The word tailoring of the immunosuppression, and the second best immunosuppressive protocol is individualization. No universal best one yet. Transplantation, as all medicine, is continuum. That's why pediatric transplantation, as well adult and aged, is preferred and maybe a must. As a rule of thumb, pediatric and young need more immunosuppressive. Professor Fatina will be here. Maybe she will debate about many things which I will mention. Need more immunosuppressive because of, but at the same time think about malignancy in pediatric, puberty, bone, and infection. Whereas the aged population, the word frailty mentioned yesterday by Professor Tariq Hussein, need less immunosuppression. However, pediatric prospective need less immunosuppression as they live longer, hence more vulnerable to more drug-related adverse effects. This is actually the most important practical figure, I tried, but I didn't fill the gaps yet. We have at least 6 different populations. Of course, the very old and the very old has no data. Even the old, if you go to the up-to-date or Lexis.com, they said adapt the adult. In pediatric and adolescents, and comparison to the adult. And we have induction maintenance and other treatment. Of course, the rest of the graph is complication if it is different as graft survival versus patient survival. But the thing which I want to put is the mTOR issue, because I indulged in transplanted at 25 kilo, and I was thinking of giving everolimus with those cyclosporin, but actually there is no data. Even if you go to the up-to-date, the mTOR, if the sirolimus cannot be used except after 13 years of age, and actually with a latent concern. Of course, the thymoglobulin is used, both of them, but the basiclismab dose, a dose which is less 10 milligram. There is no almodizarcampath has got off-label, actually, if you go to the up-to-date about induction, 30 milligram. But actually no data in the pediatric. The rituximab is just mentioned, but no concrete evidence of that. The thing about the PrEP, if you go to pediatric, think about 2 things, alternate daily and tapering. And if you go to the cyclosporin, it is 9 to 3 milligram plus 3 milligram per kg, but actually the dose has different protocols. But the younger pediatric has need higher and required higher and need to be tolerating higher. Actually, they can tolerate higher. The ASA, of course, we use it 1 to 3 to 5 milligram per kg, but actually no mention about it in the pediatric, as far as I know. The MMF, including different protocols, but if you go to the pediatric, it depends upon the body surface area, which must be, if it is less than 1.5 square meter, must be 75%. If you go to, we're using sulfamethoxazole and trimethoprim, of course our dose is 800 plus 160 twice a day maybe, but if you go to the pediatric, the dose is related to the trimethoprim and not the sulfamethoxazole. It is 10 to 15 milligram per kg. Optimization does not mean that you will go down. It is selection and no minimization without biopsy. And we need to maintain the balance between immunosuppression and less rejection and less infection. Of course, we have a developmental phases. Infancy has got a certain things to think about, responsiveness to environment and the caregiving. If we go to the early childhood, there is factors predictive, the later social compliance as got language, control of emotion. If you go to the childhood, this is emerging, maintaining attention. Most of our patients actually from 15 to 30 years has no compliance because they are emotionally, I can say, not 100% stable. Adolescence, sensitivity to feeling and conflict of resolution. So there is an imbalance in this adolescent brain from cognitive regulation and emotional reactivity. That's why prescribing transplantation drug to this category, although we don't have data, I didn't find the data about the adolescents in particular. Of course, transplantation is continual, as I showed you last year. It is tacrolimus going up, but is it better? And MMF going up, is it better? Questionable. And mTOR going down. Steroid, of course, going down. Yes, it is better. And the interleukin-2 is going down, and the thymo, ATG, is going up. But efficacy and use can be. But think about, we acute rejection going down, but our long-term graft survival didn't go. We can think of 3 things influence individual response to treatment. Human variability, including the age, of course, because infants and neonates has got drug distribution different in neonate than infant, and children metabolize certain drugs more rapidly than adults. That's why in the coming slide, the extrapolation from the adult study is not 100% correct. And the adult experience a decrease in different many physiological function, decrease in the effect of activity as gradual. But in the elderly, that's the main reason in the elderly, they consume more drugs. That's why the terminology, not only drug-drug interaction, but drug-drug infection, as I will show you in a minute. Of course, the pharmacogenetics play a role in individuals, especially in the adults, and the body weight come in the pediatric because the dose adjustment based on a body weight generally not made in adults, but weight, and most importantly, the body surface area is important for kids. One of the important things in the extremes of age is the psychological factors, because it can influence the responses to drugs, and actually it can influence the adherence, the compliance of the drug. As you see, this is about 15 years. We declined the acute rejection. We didn't decline it much after that, but we declined it. But still, if you extrapolate any of this curve, even in 2006, the long-term graft survival didn't change much. And we have different algorithms of getting good function of this. That's why the drug is important. Think about this to see the difference between a young and adult. Even smoker and non-smoker, I will not go to this and effect of smoking, but especially the young is more vulnerable to ischemic heart disease. That's why even non-diabetic or diabetic, so the age will have a difference. We must appreciate that we have no prospective randomized control trial to evaluate the optimal immunosuppression yet. At the same time, even in the pediatric group, we have increased malignancy as we saw in the cases yesterday. Of course, Kaposi and PTLD is coming the top. But not only that, the most important about this, because the pediatric need more immunosuppression at the start, but try to get it as lower as possible. Because if you see this curve, this is adjusted for age. And as long as you live, the increased incidence of different malignancy. So there is another drug-drug interaction, and actually the terminology is drug-drug infection. A major concern. It is a reality check of different things. Of course, the cadaver and the life-related increase, although this is an old data from 2000, but still increased to 21 years. And it's important in this slide, we lag the response to a change in function of the individual as an age, and function in his concern about his drug. Just one thing, of course, the most important is the endpoint, the effects. But to go to these effects through a pharmacodynamic, which is the side to the effects, we need the pharmacokinetics. But if you go to the elderly, the most important is they have a polypharmacy. That's the problem. That's why the fall and the CNS pharmacy is important. The drug-drug interaction is increased, different drugs, this is the problem in the elderly. A lot of drug with a lot of interaction, I will not go through this, but this will decrease different things. The problem is this not 100% avoidable. It can be avoided, but still we cannot. That's why the importance of prescribing drug in the elderly. So the age, and this is coming from the European Human Medical Practice 2008. The age high as well as low is important unfavorable risk factor in transplantation. As age of recipient is increasing, confirmatory study should reflect a sufficient number of elderly above 65, as Professor Hafiz mentioned. The influence of specific risk factors should be investigated, as accurate diagnosis and treatment, especially of the cardiovascular, is important. But the problem is the drug in pediatric cannot be extrapolated 100% from the adult. Specific clinical aspects should be detailed as age category, ideally pediatric trial design, and that's the code, should be developed while the phase of the adult phase is reaching number 3 before thinking about adapting this in pediatric.
because the pharmacokinetic may be different. But the most important is, for efficacy assessment in pediatric population, reduction of corticosteroids means dose and treatment duration, but consider injection treatment, the rate of severity of infection and quality of life, and adherence to the treatment. That's the killer of us. And for safety assessment, organ maturation, growth and sexual development, and long-term treatment. So still in pediatric strategy to minimize the effect and can be efficacy extrapolated, but not 100%, because extrapolation may not be the right way to approach to do, because of different other things is to be considered. Still, the good things in pediatric compared to the chronic dialysis, the kidney transplantation is better in pediatric, but the bad thing in pediatric, think about this. If you see the curve, the infection is much more in pediatric, and look to this curve, from 0 to 4, the cause of death is mainly infection in pediatric population. As regard the age going down, the infection, that's why we need vaccination. But the bad is the infection about this pediatric. The small children have the greatest number of infection rather than adults. But what about the ugly thing in prescribing immunosuppression and doing transplantation in the pediatric group? That's the reason. It is PDLD, because it is more common. And think about, this is Transplantation Journal, maybe 2005. Look to the first curve. If it is less than 20 years, it is increased PDL. Of course, there is other factors, including difference, including induction, quadruple immunosuppression, and if no cyclosporin is given, I don't know why. So malignancy in pediatric prevention is important, and this ugly, the largest cause of death in the first kidney transplant recipient, it is include 10%. So young children have excellent long-term outcome after kidney transplantation, improvement in linear growth, infection complication, and high slate optic. But think about this. The mTOR is not here if the choice of antibody infection, antibody induction, but it is not extrapolated because no data. So coming to the end of my talk, you must think about these three circles. It is the patient which is a kid will grow and later maybe an adult or old. But think about adherence, compliance with the least and the best. So, Mr. Chairman and my dear professors and colleagues, in absolute terms, it is not the age adaptation to immunosuppression, but it is the adherence and the compliance. That's the cause of donor-specific antibody, with the least side effect and the best long-term survival, but mostly individualization. And thank you very much.
Thank you very much, Professor Ahmed.
We can have a question also. Okay, thanks, Professor Ahmed.